interests? Any councillors disclose an interest? We are actually changing things around because I thought we'd ask the providers to give their address first and then you can ask questions. So that's all right for the rest of the committee? Yeah. So right, I'd like to welcome Lynette Wells and Ruth Farr from the East Sussex Healthcare NHS Trust and Graham Griffiths and Charles Marr from the Clinical Commissioning Group. And they'll be talking to you this evening. I don't know if you've got any particular one you want to go in.
I think I'm going to go first.
Okay.
Yeah. Are you ready now?
Yes, thank you.
Can you hear me at the back? No?
No.
Okay. So would it help if I came and stood out there and spoke? Yeah. I know I'm quite softly spoken, so is that okay? It's here better. Can you hear me now? Okay. Can you hear me? Okay. So I'm from East Sussex Healthcare NHS Trust, and we're what's known as a provider. So we provide services to the local population. And Graham is from what's called the Clinical Commissioning Group, so they purchase services on behalf of the public from us and from other providers. And we, in our list of services, so we provide Eastbourne District General Hospital, Conquest Hospital, some of the community sites, so Bexhill Hospital, Rye Hospital, and we also provide services from Lewis Hospital and also as far as Cobra and Upfield, although we're not the main providers of Lewis anymore. And we provide your community services, so if you need district nurse or a health visitor or something in the community, it's highly likely that we will provide those services for you. We see 130,000 people through our A&E departments every year, so you can imagine it's very, very busy. 3,300 babies born, 90,000 patients we see in the community. Our community nurses have 90,000 of you, and every year we do 5.5 million oncology tests, and 380,000 people come through outpatients. We're not GPs. A lot of people do some of these people do like to talk about GPs. We're not GPs. We also don't provide social care, so nursing care in care homes. But we also work with those providers to make sure that your care is seamless. Our income is £356 million. A very big organisation. If I just talk a bit about the organisation and the year we had last year, many of you will see it was a year of two halves with us last year. So we had a big care quality inspection. In fact, we had two inspections, one in September 14 and one in March 2015. And the March 2015 report was published in September 2015. And you may already be aware this report was quite a lot in the local press. We were found to be inadequate. Not inadequate across everything. In fact, we found good across the board for caring, but in terms of well-led and governance and some other areas we were inadequate. And we became what's known as a special measures trust. Again, we read all about that. So the report's highlighted a number of weaknesses and failures across our organisation, and we put quite a lot of work and a lot of commitment into improving quality and safety of the trust. So I'll talk in a minute about some of the things we've done. Like most organisations in the NHS, we are facing financial problems. We finished last year with a £48 million deficit, and due to the volume of people coming through our A&E departments, again, it's very, very busy, and some of the standards we have to meet, so that when you come into A&E, for example, we've seen within 4 hours, we struggle to meet that. We're meant to get 95% of people meeting. So it really was a year of two halves. So the first year was not great for the organisation. We had a complete turnaround of the trust board. So our chairman, our chief exec, our director of finance, director of strategy, director of operations have all changed. And there's a real commitment and ambition of the organisation to be outstanding. So there's lots of work going on. So what have we done? So we've been working quite a lot, really, really hard to improve services and access to services, and also working with our leagues and frameworks inspections and regulatory work. And they've been doing some work. They did 24 hours in our hospital. So from a patient's perspective, to give us feedback about what it feels like, you know, your journey as a patient. They've also looked at complaints and given us feedback about, you know, how it feels, you know, some things that we improve do, you know, do better in our complaints. We've got radiotherapy coming out of the DJ. So at the moment, if you need radiotherapy, you have to go to Brighton or Maidstone or up to London. And a new unit is due to open in the bottom of the endoscopy in the spring of next year, which Brighton operates, and then again, quite excited about that. We've recruited lots of staff. So our nursing establishment, the number of nurses on board has increased from like 300 additional nurses on board to Cardiff. So again, we're really proud of that. Your health records are, and a lot of people are quite surprised about this, and we do hold some of your information on computer, but actually when you come into hospital, we still keep lots of records by hand, and we'll get, you know, there's big folders you'll see, the doctors, the cat, you know, we still keep them in paper. And we're moving away from that, we're moving into an electronic document management system. So, and that again is about sharing information across the health department to make care seamless, so we can share information with GP better rather than paper records. And we're also scanning the records, so we have like a barcode, the actual record, and know where it is, and it's not lost in the our penalty units is refurbished in the National Council. Quite starting, it's really nice unit now, it's training around that. And we've done a lot of work around improving privacy and dignity, so when you come into the A department, we're looking at reconfiguring those, so it's a much better environment. And also doing things like making sure we don't have mixed-sex accommodation, which is we don't get ladies and gentlemen on the same ward unless it's in like our IT departments. This coming year, our priorities are around outpatient appointments and improving getting people there, making sure the appointments are right. I think before we were sending appointments out a year ahead, and then people would turn up and we have all sorts of problems. We've looked at outpatients, we're improving that. We're improving end-of-life care, so working with the hospitals and palliative care people to make sure that when people reach the end of their life, they're actually dying in their place of choice. Because, you know, obviously some people do want to come to the hospital towards the end of life, but other people want to stay at home or go to hospice. So we're doing all work around supporting people so that, you know, they get their first choice. We're looking at transport. We recognise that it's not easy to get to some of our sites. So we're looking at transport and what we can do. And then again, that's working with the council to see, you know, can they put extra bus services, things like that. We're doing some work around sepsis. There's quite a lot in the press about sepsis, and we're taking work about that. Meds management, so making sure when you hospital get the right medication when you go home, it's quick and again you get the right medication. And also reducing the ward moves. I think there's nothing worse than when you're in hospital and you just settle and then you'll move from ward to ward, and it's not good for patient care. The number of times we do that is reducing. Sometimes because of clinical reasons we have to do that, but sometimes we don't, it's just that we need a bed. So we're doing our best to reduce the number of those. We're preparing for our next CPC inspection, and that's in progress in 3 weeks. So they will be back in the trust to assess whether the improvements that we made have been sufficient to meet some inspection measures. We have worked really hard, and our staff have worked really hard to do those measures we can, much better than we were before. And we're also participating in lots of health economy-wide programmes. You'll see lots in the press at the moment about STPs, which are Sustainable Transformation Plans, and also East Sussex Better Together, again, is a programme in East Sussex. It's about all providers working better together to improve the pathways of care for you, so that you're not come to lots of different providers. It's going to take a little bit of time.
I've been in various different meetings within Seaford, including when we were looking at schemes to try to develop the medical centre. Lots of things, lots of people have been involved in those sorts of plans, and different reorganisations in the NHS change priorities. I started in the NHS working in hospitals, and then went to the organisation called the Primary Care Trust over in Lewis, who were responsible for purchasing the healthcare of the local population. Last reorganisation of the NHS changed from Primary Care Trust to clinical commissioning groups. The emphasis on the clinical GPs became much more involved in looking at care for both their population and others, and started leading a lot of the processes around the commissioning of healthcare. Whenever we're looking at additional schemes, new schemes, ways of changing, you've always got to take account of the fact that there is a core demand in the health service. Unless something drastically changes, people will need hip replacements, people will need knee replacements, people will need heart surgery. There is a core demand in the NHS. And so very often, I think it would have been a fair accusation to say that clinical commissioning groups, PCTs before them, PCGs before that, were tinkering around the edges because they still had to make sure that core demand and core need was met. But I don't know how many of you have been to any of the East Sussex Better Together consultation programme. I'm going to assume none, and I'll just give you a brief outline. East Sussex Better Together was a programme that was started jointly by the clinical commissioning groups and also the county council in their commissioning side, not the roads and all those, but their commissioning side that looks after health, mental health, social services, those. And looking at the nearly £1 billion, if you add the CCG's budgets and county council budgets together, how much they spend on health and health-related issues. And trying to say, well, where I said, well, we've got a core demand, we have to do that. But looking at other things like if we could keep people more well in their homes rather than becoming more ill and then going into hospital. The theory is you reduce the demand on the hospital. You always have to have hospitals. They'll always need to provide acute care. They'll always need to provide the planned care and the planned surgery that I talked about at the beginning. So there's a huge programme of works going on. Lynette mentioned some of the things that have already happened. We were looking at trying to, if we could get community geriatricians who worked out in the community rather than the hospital, then everyone went to them when they actually had become quite sick or had an acute exacerbation of a chronic condition, say. Then the GPs could refer directly to them to get that geriatrician supporting to look after them at home or in a local environment. Maybe in Seaford it would be the medical centre potentially. Then sort of in planning that, medical staff to get community geriatricians, so that was changed into a team of community frailty nurses, which is frailty is becoming more and more. There's a lead geriatrician within ESH, Lady Mucci, who's very keen on it. We sort out frailty in the community, it will stop a lot of people going into hospital, but it also help with their expectations and their end of life care if they're sort of is planned properly. Crisis response, people who have needs at home go to the GP finds he's got no alternative but to key into the system. He has to refer that person to the hospital. They get into the hospital, generally into a bed, and then all the diagnostics happen around them in the hospital, usually over an extended period. And so the whole idea is to change that type of care into those into those schemes. The County Council always ran a telephone call service for people to be able to ask questions, and professionals to be able to key people into some of the social services. Health has linked up with that now, so GPs and other health professionals can phone onto a helpline and get their patient, excuse me, their patient referred directly to services rather than them being queued through the hospital. There's a lot more around East Sussex better together, but those are some issues where we say, well, we don't just have to reflect what's happening. If we can start to change around the margins and have bigger programmes affecting more people. Within GP practices, you probably could imagine, and it sounds obvious, that GPs will know of their patients who, I don't know, say have asthma or COPD, who generally keep themselves well at home, but sometimes something will tip them over and they'll need to go into hospital. So if they identify those patients up front, and we set up a scheme where we have community nurses, community practitioners, maybe physiotherapists, going in to see those people regularly or contacting them, checking that they're taking their medications, checking that they are getting, having a good diet, and those sorts of things, and to stop people rolling over into having to go to the hospital. So the ESBT programme is around all of those sorts of things. The clinical conditioning group's role in that is to try to push and to kickstart those changes. The hospitals generally, I think it's fair to say, find themselves overwhelmed with the numbers that Lynette came out to about the numbers of people who have attended accident and emergency. And so it's incumbent on the CCGs and the County Council social services people who aren't under that immediate direct pressure to try to work within the system and then work with the new teams that Annette told you, Adrian Bull and Chief Exec Kadesh, is very keen and has now joined the programme. So it's not just now a programme where commissioners are looking at the services, but also the providers who actually know how things can and could be done. So that's steaming ahead. Another part of our role is, and nationally we're required to do it, is to monitor the national constitutional commitments, they call the 18 weeks maximum waiting time for 92% of the people going through the service. There are 7 different cancer targets, 2 of which are not routinely met locally, and those are both around 62-day full treatment, 62 days from the first referral to full treatment. Usually the failures around those, I've used the word failures because that's what they are called nationally, are around complex multidisciplinary issues. We don't have access to all of the like PET scanning is something I just don't think we still have in ASH. Pretty confident we don't. And so certain cancers where they have to involve clinicians from Brighton, clinicians locally, patients, those targets are not hit. The target for that at the moment is, do you know, I'm going to make it up, it's about 85% of all of them have been considered. It's around that. And currently we're hitting about 84, so we're not a million miles away from it, and we're still not hitting it. Excuse me, I'm going to get some water. Either that or I've got all lotion. Thank you. Sorry if I'm going on too much, but I was going to say also, so the CCG's role is in monitoring the standards of the hospitals. And it's the hospitals, because we obviously buy healthcare from Brighton, we buy some from Ashford. Most, probably 80% of the healthcare that the East Sussex CCG buy is through East Sussex hospitals. We also pay for primary care for the GP's practices. We pay currently around £90 million worth of drugs that they prescribe to local residents. And there is a statistic that a good 35% of that is never taken. And so there are schemes being worked up about why people will continue to have their repeat prescription filled but actually not take their medications. And that we've got a couple of very senior pharmacists who are working on those and working to reduce that. Part of it is the GPs reviewing the medication, but I thought it was quite staggering that 35% at least of the money that's for drugs prescribed over the counter is then not taken. We also pay for specialist care, so the CCGs hold the budget for all of the care, so heart care, kidney care, dialysis, which is all called specialist treatment. We still provide the budget for all of those treatments. I don't think I'm going to big up our role anymore. I think there's people who've got lots of questions to ask, things they'd like to know. I'm not going to absolutely commit that between us up there we know the answers to everything, but what we will commit to is to come back and maybe via yourselves we come back to get responses, or if we take email addresses or something. So I'll finish there.
Thank you. I will propose to suspend standing orders. Councillor Miller?
Yeah, could we go back to basics, please? Could you just clarify what healthcare is offered by Hastings and what by Eastbourne? Because I think there is still some confusion about those services, and personally, in the past week, my mother had to go into hospital, and I was a bit horrified that she wasn't sent to Eastbourne, and we were given the choice of Hastings or Brighton, and I didn't feel like that was satisfactory, and apparently it was because she needed a referral to a surgical team. And that's not something I was expecting.
So we provide emergency services on both sites. At Eastbourne, we centralise stroke care. So we do a really, really good stroke service. Can you hear me back? So we've got a really good stroke service at Eastbourne. If it's an elective procedure, so a planned procedure, it's likely that you will go to the Conquest Hospital for that, but not for everything, but it's likely that you will go there. Trauma and orthopaedics is also at Conquest. We have a midwifery-led maternity unit at Eastbourne, and at Conquest we have a full consultant-led maternity unit. And then obviously we provide services in community hospitals as well. So we've got some really state-of-the-art services around orthopaedics and eyes at Bexhill. So it's there is some duplication on both sides, but we also do have some side, and that's around making sure that we've got specialty services and the right number of consultants and clinicians to provide the best care.
So as a supplementary then, do people like that happen to you, have personal circumstances, always have the choice of Brighton and Hastings?
I'll answer that. Everyone's seeing their GP, and then following that, when if they see a consultant in hospital, should be offered choice. So, for example, you could say, do you know what, I'd rather you go to a hospital in Devon, and if it's an NHS hospital, then you're entitled to ask for that. Locally, and what behind some of the questions is, services can't order. In some ways it's not even economic to think of just having exactly the same on both sides, buying all the same machines, all the same, but a lot of it is also driven by the availability of the doctors, the clinicians. So for example, when I worked at probably 8-9 years ago, we had to make all emergency ENT surgery or work off one site because there wasn't enough medical staffing to run two full-time 24-hour rotas. And that wasn't because we didn't have the money to do it necessarily, it's because the Royal College wouldn't recognise that number of patients, because they're also saying that each let's say a surgeon in this case, has to keep up a number of cases to maintain their capabilities and their quality. So in some cases, in the case of ENT, there wasn't enough emergency ear, nose and throat activity for the Royal College to authorise us to have that number of doctors. So there are quite a lot of things that drive whether you can have them both, everything replicated on both sides. In our case, there are two sides, one in Eastbourne and one in Hastings. But if you when you go to see your GP, or even you get to a consultant who says you need X operation done, you can say, I don't want it here. I'd like to be referred to Brighton, or I'd like to be referred to another NHS environment, and that's sort of nationally enshrined as patient choice.
Councillor Fulham.
Thank you, Chair. Just disappointing to not hear any mention of Seaford in either of your presentations this evening. Back in 2011, the Sussex Healthcare Council published figures of the population count. Lewes was 17,297 and Seaford was 23,571. I'll choose Lewes as a reference as they have less of a population than Seaford. In fact, Seaford is the largest town within the district, yet Lewes has a minor injuries unit and we don't. Currently, for those of you residing in Seaford, we are looking down the barrel of a loaded gun with an increase in population for a forecast of over 500 plus homes. This will increase the load on already strained and outdated medical provision for our town and obviously the other infrastructure. My question is, what criteria do we need to attain in order to have sufficient medical services to cater for our needs? I recognise that not everything can be done and delivered here, but quite honestly, our town deserves a whole lot better. Good luck with the reception.
Thank you, Jen.
Anybody want to answer that?
Yeah, I'll have a go. Over the years, I did sort of mention, probably legally, that when I first joined the PCTs, I was asked to join a group because there was a lot of work looking at what could happen around Seaford Medical Centre, whether that could be expanded. Even the Town Council at the time had a view that they might be able to get hold of some land at the back of what sort of really call the recreation ground and to extend that. We couldn't get capital monies at the time through NHS Central for that work, and there was a group of your colleagues who went and in the end met with Norman Baker and with the Chief Executive of the PCT at the time, and they went through that and the rationale. One of the things I also said, and it is sort of a factor, is that Lewes has always had that hospital, and it's been Brighton used it a lot for elective surgery, or they used to up until last year. I haven't kept in touch with them. Crowborough long had a community hospital as a Blackpool, and Bexhill had the Irving unit, which is now also part of the stroke care or rehab. So the honest truth is that a lot of what is provided reflects historically. So your question is then, so how do we change that? And that was something to say we were working on. We looked at whether we could have a minor injuries unit locally. We looked at the volume of activity, looked at the volume of people that went from a Seaford, both Seaford postcodes and who were registered to Seaford GPs into either Brighton or Eastbourne as either minor injuries or accident emergency activity. And I have to say at the time, with what was happening, we couldn't make an economic case to create it. At the same time though, the GPs were providing or are providing it's not so formal. Maybe that's the route we should go. If my understanding is if I went into Seaford Medical Centre, my practice, with a cut hand, they would get one of their practice nurses to deal with that as a minor injury. That I'd say, well, and for everything I say, I'm willing to bet someone will have had a different experience in the room. But that's theoretic. GP practices are paid for providing minor injury services as well. So I'd have to check whether they have still kept that up. At the time I was doing the work, that was the case. It sounds like people put their hands on it, maybe not the case now. There's also a response I've heard that everything we pull away from the hospital in terms of some core services, the less viable the hospital becomes as well. And I think that is an important thing to point out, which is why we're looking at all the emergency stuff, the stuff that actually really affects the throughput in the hospital and the flows. It's a fine balance between ensuring that it remains viable and that we're providing services in the right place. I'm still not answering your question. I'm aware of that. So how do we get additional services in Seaford? I didn't mention Hailsham. All of those localities have the same arguments, although I think to be fair, Seaford is a large town with a large population.
We've got a large town in the district, and forgot what that's how we certainly in the doctors
Yeah, and I've been around hearing those arguments ever since I joined the PCT. I've seen, I believe, improvements to the primary care offer, to the GPs, to what they do. I know the work that's going on now in order to stop people having to go to the hospital where they can be looked after closer to home. But at the moment, I'm honestly, personally stumped saying, well, what other services would we get locally? There is under the East Sussex Better Together programme I think localities. So the Eastbourne, Hailsham and Seaford, for example, has been broken up into some localities. They're trying to ensure that all the community nurses who are employed in the NHS are identified to work to those localities, and that those localities eventually are given their healthcare budget to buy the healthcare for their population. Now that's not going to happen tomorrow, but it's within a couple of years of saying. So that's the direction to go in recognising that different locality areas have. They have the same core needs for some core medical services, but there is a possibility that the local GPs and others could say, do you know what, we want to provide that here, and we think we can provide that much more efficiently here using our budget in that locality basis. And I think that's probably the one that will really kick some of those local changes.
Thank you. Councillor Brown?
Thank you, Madam Mayor. I've had occasion to visit Eastbourne District General Hospital over the last 12 days, and I'd like to congratulate the hospital on the level of care that's been shown to my relative, particularly A&E, the MAU and Richard on board. However, during that time I spent between 4 and 12 hours each day in the hospital, and I paid out £74 in parking charge. £74. You think that's right? How much of that money actually goes to the hospital?
So, it's a lot of money, I agree with you. The money does, it comes back into the hospital in terms of, we have to pay security in our car parks, so to cover things like that, to make sure that your cars are safe while they're parked in our car park. It also covers keeping the car park up to a certain standard, so making sure the tarmac and things like that. But, we have put our parking charges up for a long, long time at the trust. I know it's a lot of money, but every time it comes to the board, our board strongly resist it, even though the cost of employing people in parking gates and keeping everything up is going up. It's something the board haven't, our charges have gone up for a long time because they're aware of that. And I know that when people are frequent visitors, so if they, for example,
either a sort of free parking or reduced parking rate.
All I'd add to, my understanding is that all of the money, I mean, they pay a fee to a management agent, but the bulk of the money does go to them. It is reported in your annual accounts.
It is, yeah, and I can't remember how much it is.
I mean, I read in the papers, I think only this weekend or last weekend, it's a huge amount of money. Isn't there an ability, doesn't it say on the machines that if you happen to be a regular visitor, you can buy a...
I think you can. It's not. I'd be making something up if I sat here and said I know all about the parking section. It's not my. I can certainly go away and find out a bit more about it for you, so that I can answer you. But I'd be making up if I was saying there was.
I had experience of this last 2 years ago. My husband was in for 8 weeks, and actually managed to negotiate a long-term parking ticket with the parking attendant there. So it might be worth speaking to them.
I don't disagree with that. There is schemes where you can buy 5 days, 10 days, whatever it is, parking, but when you're taking each day at a time, I'm not
Yes.
Councillor Meiji?
Thank you. Actually, before I ask my questions, I've got a couple of follow-up questions to a couple of things. Graham and I think we've been meeting for the past few years, so and as well know, we've been fighting for the past many years to get services in Seaford. Something that you did say that I accompanied with was in reply to the answer that Councillor Lower gave to you, that patients do have a choice as to where they are. Yes. It's not. I had a case of a gentleman who had called an ambulance. The ambulance came and took them straight to Brighton. Obviously, you had an ambulance. After Brighton, they were transferred to outpatients in ABC, or sent to ABC. So you might be someone from Seaford going to ABC. The ambulance driver should give them the choice, say where do you want to go? Do you want to go to Brighton or do you want to go to Eastbourne? So I think we need to get your ambulance drivers to give patients a choice, because that makes it different.
If I could just respond to that one, if I may. I was thinking of elective care where someone has said, oh, I've got to see my GP because my knee hurts, and then the GP says, oh, I'll send you to Eastbourne. You're saying, well, if it's an emergency, the ambulance drivers will and always will make a decision where they think they can get someone into quickest for the appropriate care. So I apologise, I did that. For emergency care, the ambulance driver will always take someone where they think they can get in quicker.
And then something else I want to just address, another follow-up, was in terms of something that we've been trying to find for many years is to get services that are done locally, and the framework that we've put in the CCG is very simple. ESH can do acute care, whereas community services and community care and outpatient can be done locally in Seaford. There's no reason why you can't do that. Brighton does it, Brighton BSUH does that very well. There are stories of consultants coming out to see patients in Seaford, whereas ESH would not let come see patients in Seaford. Patients have to travel down to ESH. So I think the first question we need to look at is that there are scope, and I have had meetings with yourself, and there are scope whether we can provide more services in Seaford that would not take anything away from ESH. So ESH can do acute and A&E, but things like consultant visits, X-ray can be done in Seaford. We have August centre in Seaford we fought for, and right now they've been trying to bid for services from yourselves. But again, CCG wouldn't commission services with ESH before we look in Seaford. So I think the first point is that it would be nice for you to take that away and look at how you can provide some services in Seaford which everyone would likely value, and that would not take anything away from the acute services that ESH can provide. Second point that you state, you talk about primary care. Primary care in Seaford is basically nothing, is dying. There are patients waiting for weeks to see their GPs. Again, the CCG has the role to play in primary care. Now, something that we've again suggested to the CCG is quite simple. We need, especially with new buildings being built on the Union's website, on the Union site, we need more primary care in Seaford. I've been talking to someone called Molly King, Molly is left now. I've been told to talk to me, Mr. Wolfgang.
Yeah.
Wolfgang. So, again, the CCG isn't talking to us. We want to, the GP is saying they're quite keen to do something. The CCG is saying, well, nobody knows what's happening. But we know we can work together. We're actually quite keen. We've got still money from Lewis District Council coming into Seaford. We can work with the local councils. There are buildings we've identified in Seaford which we can use for this. But again, the CCG isn't coming forward. So again, if you can come back to us, let's look at what we can do with primary care. So we improve primary care in Seaford, because again, that is a big issue for Seaford residents. Very quickly, there's something called any qualified provider, which is CCG. When the CCG was created, we were told any qualified provider will help make you have your services provided locally in Seaford. We've tried to use any qualified provider to bring in a supply. We know suppliers health suppliers who want to come and supply services to us in Seaford, but the CCG wouldn't play ball. So again, therefore, if effectively there are ways people can get services done in Seaford if the CCG wants to work with us. So I think my question is, why aren't you using any qualified provider provision? How can we use that as the back door to get more services provided in Seaford, so our patients, residents are not having to travel to Bexhill, East Conquest, Hastings, or Brighton for local services. Very good, very briefly as well. So something else, not for Ash, I've got some questions for you. One of the complaints people have is transport. I know an 80-year-old woman who had to go to Bexhill for the things that some eye injection of ophthalmologist. And imagine an 80-year-old woman getting to Bexhill. There are no direct transport. There are no direct public transport from Seaford to Bexhill. Now, if you look at BSHU, the Brighton Hospital, they provide free transport both from Brighton to Hailsham for their patients. If you look at Lewis, they provide free transport using CTLA for their patients. But we've asked Ash to do this, not for everyone, but for patients that are actually quite clearly vulnerable, who cannot get to the outpatient facility. Ash just refuses to do that. So I think we need to take that away and look at how we can provide transport for our very vulnerable patients who get to hospital. Something else, very quickly, I'm not sure if this is H or the CCG. If you're talking about Lewis having wonderful services, Lewis has got this thing called the Lewis Health open in North Street Quarter. I know the CCG talking about having spokes and ops. Is that what you call it?
Hub and spoke.
Oh, that's yeah. Again, you open a new one in Lewis. It's going to be, I'm actually going there tomorrow to see it. You get nothing in Seaford. And I don't know why you're doing this, because every time people talk to you about it, you say you've got the money. Well, yes, you can do a new one in Lewis, so everyone coming together to do that. And when we're not having that in Seaford, so again, it'd be nice to know why that isn't happening, and how can we go about having a spoke in Seaford. My final question is about SIL, something called Community Infrastructure Levy. I've written to your Amanda report about this. So if we get some SIL, Community Infrastructure Levy, give to us building some form of hospital in Seaford, will the CCG come and work with us on this? Again, the CCG is saying, well, we don't know, we're not interested. We only commission services, we don't provide services. I don't think that's we do this, but that's not a true response, is it?
But it is how the government has set up the council, that last one. And that's why, I mean, the net said we're provided. I know the language sounds nonsense to me, but the CCGs, some of you might remember that in the PCT days, PCT used to run all the community services. But the government decided before CCGs came out that actually commissioners could not also be providers, which was why we had to go through a process of then moving the community services, and eventually they went to Ash. So the fact that we can only commission it's a function of the way the latest organisation of the NHS to do. So we aren't allowed to provide. I've made a note about the Lewis service. I didn't hear what it actually was, but that's High Royal Lewis and Havens,
Yes.
and I'd be interested to know how they did that. I'm not going to do the transport, but AQP is another process which was set up. Any qualified provider, which call it NHS Central, the Department of Health set up to bring other providers into the health service. And so the CCGs we were given a process whereby we authorise them if they complete all the paperwork and they have all the right certificates and all that to provide a service, but we're entirely dependent on someone coming forward and saying we would like to provide X service. Audiology was one that there are quite a few any qualified providers. In some outpatient specialties there are them, but they have to come forward and say we would like to provide services. They don't even have to specify in what area, but they set up. I don't think there's an audiology outlet in Seaford that runs under that. So it's not within our gift to create them. They have to say we're a commercial enterprise and we want to be qualified, and if patients are referred to us, to them, we have to pay them once they're qualified.
So just for the two GP surgeries, I've met with them, and they actually created their own their own company to provide services in Seaford, but the CCG wouldn't commission services from them.
I probably shouldn't, but I'm going to say I'm not aware that they made any bid for any services, and I would leave it at that. GP services and building is saying that GPs are independent businesses who contract with the NHS, and if they wanted to expand their premises and do more services, they're an independent business, and all they have to ask the CCG is, would the CCGs have to pay their rent and those things, what would be the commercial rent for their premises. So if they wanted to expand their services and use other buildings locally and then provide services from that, it's for them to go to the CCG and say, we'd like to do that. Are you prepared to pay the additional rent that would accrue? It was only last year that it came back to us. PCTs used to have that process. NHS England, when CCGs were formed, NHS England took it over. They've just given it back to us. And I know that there are discussions going on in lots of areas now from GPs, practices with the CCGs, saying can we find the additional money to pay additional rent if they expand their premises. And our question back, our answer back to them will be, yes, of course, as long as you're providing services that are actually needed by the local population, then we'll have a discussion with them. Yeah, I think I've answered. With the X-rays, as you know, we did talk ages ago about that, and I have been talking with the boarder, and I've given them all the numbers that are done for local residents, both for the new MSK service, the musculoskeletal service, and also the chest X-rays and all those sorts of things. So they have all the numbers, and they waiting for them to come back to us to say they actually want. I believe they do want to provide it, but they're a commercial company as well, and they have to, and I've told them how much we pay for those things, and they've got to see if they can provide them for what is a national tariff that we pay.
Just very quickly, are you therefore committed to bringing more services to Seaford, at least to the other centre? Because it's there.
The border centre, I can confirm to you, and as they may well have told you, that I've been there and visited them and met with them and talked to them, and I followed that up and given them the numbers of X-rays that are done on the local population for in two MSK and non-MSK, you could say. So all of the, I don't want to call them bog standard, but chest X-rays, wrists, all those sorts of things. They know those numbers, so they know how many they would be doing, and they know how much the NHS pays for that. They're probably doing their commercial calculations to check said to them is that once you start doing it, you can't say, oh, we can't do it this week, because it's got to be a regular, consistent service.
Finally, why can't we have consultants come to Seaford to see patients, which is what Brighton does?
That's being worked. I think that's being worked up as part of the East Sussex Better Together programme. It is about the localities that Graham talked about, and it will be about providing care in localities, and we are looking at whether or not some of our consultants, in fact some of our consultants do go out to the community for some things, but we are looking at, but it's also that economies of scale, because obviously we don't have hundreds, we have trouble with recruiting consultants, we don't have lots of spare consultants, so to bring them out in the community, it has to be for a full clinic, so it's quite a lot of, it's not just as easy as saying, well, we'll send you out to Seaford for a morning, because obviously we need to make sure that there's, the workload there for them to do. But it is something that needs to be better together. It's one of those strands of work. We do provide community services, so although you reference trust being acute, we do provide community services, and some of our newer community services that we set up as part of East Sussex Better Together, so like the frailty service, there is a dedicated team looking at Seaford. I think that's one of the localities where there is a team. So there is quite a lot of work behind the scenes around doing as much as we can close to home. It doesn't happen overnight. I'm sure we'd like it to happen much quicker than it is. But there is a really focused piece of work, and this we are contributing to. Transport. If someone is frail elderly, like your 80-year-old lady, she should be eligible for passenger transport. So if you are elderly or very sick, there is passenger transport provided. It's provided by a company called Code of Forma at the moment, but the GPs should certainly have, well, we don't provide it, what I'm saying, but we have access to it, and we can certainly look at it for our patients, as can the GPs and other patients.
Well, I would add to that, because in particular, the ophthalmology services did used to be provided from the DGH, and they did used to be provided from the Conquest, and ESHT, particularly their doctors, made an argument that if we could centralise it, we could have all our skills, we could put all the kit, and we could run a really good service. And I'm pretty sure one of the conditions of us agreeing was that ESHT agreed transport for just those sorts of cases, because it clearly was going to be an additional journey. So we will take that away, and I'll talk with, it's not your area in there, but I have made a note, because they are supposed to, I'd even say for GPs, I know I'm sending you to Bexhill, they should know how to get transport booked. So we'll check for that. But it was part of the conditions of that service changing that was set up. I think we've answered all those.
Councillor Worcester?
Thank you. A lot of what I was going to say has really been covered now. When you look at the population of Seaford, it's an elderly population, I think. Most of us would agree. There's a lot of widows and widowers, and this transport problem is the one that people will talk to you about most. A lot of the elderly no longer drive, and it's a real problem for them. It worries them. There may be means of getting transport, but it worries them, it plays on their mind, they come back to you. The other thing is, it's been mentioned now, this question of consultants coming to Seaford. Now, I've had heart problems, and the heart specialist comes over to Seaford, and it's really nice, because virtually all of their hospitals are not easy to get to. There's no red bus service to Eastbourne, it's a hill to Brighton. If you get the 12, you've got quite a steep hill to Mountain. It's a nightmare going over to the complex. So it's these everyday things that play on people's minds.
I will take that back, because it's something that I kept harking back to when I first joined the PCT, because I knew the hospital services, because I'd worked there. I was looking at what services could come out, and I had a list, and I'd worked. Jeanette says, and I mean, there is a balance to it, and it is an argument that even consultants would make. If I sit here with all my team around me and all the support around me, I can see 150 people in the morning. If I go out to Hailsham, I'll see 20 people in the morning, and there are others. But that's not the end of it, because you can then say, well, okay, if they did it once a month, and then you can see you could build up a decent load of people for them to see here. And so it's not impossible, and I think the world has changed a little bit. That hospital specialists will be more open to going to other areas. So I will undertake to start looking at what specialties in particular would, are the numbers there to do, and maybe the convenience if it's for older folk. I would actually like us to be able to get some more assessments for older people locally, so that, but then maybe the frailty service I talked about that we set up will do that anyway. But I was talking with the local practices about all of the people get sent into the DGH to be assessed for, what's wrong with the why does she keep falling over, why does he keep falling over, those sorts of things. Parts of the services that are being set up now under crisis response and the frailty service is to look at, well, it doesn't always have to be a consultant, it has to be a well-trained, knowledgeable clinician of another badge. But I will dig out that work and get some of the analysts looking at it.
Councillor Gorman?
Just could I ask the members of the public to wait very patiently this evening, and then perhaps us as councillors just stand out the things public to ask.
Suspense funding orders. Seconded. Agreed. Okay, standing suspended. I believe Councillor Lambert had something to say. Thank you.
Thank you, Councillor Carolyn Lambton, County Councillor for Seaford Blatchington. I just first of all wanted to give you the heads up that I have heard from a lot of residents who are not able to be here tonight. So I've undertaken to gather together their issues and concerns, because it's important that those are, I think, heard by you. And I'll email them, if I may, to you after the meeting. I completely support the concerns and issues that colleagues have raised. Seaford is the biggest town in the district, and frankly we have been woefully underprovided for years in terms of health provision. You're absolutely right, Graham. Norman Baker and I got within a hair's breadth of getting a minor injuries clinic, and then the government changed the funding structure and that was withdrawn. But we are where we are, and I do believe that we can put forward some positive ideas for change. You've talked quite rightly about the locality funding that I know the other CCGs are using very effectively. And I just have to try and push you a bit on that and ask if we cannot get some locality funding, even for some pilot schemes, because we all know, sitting in this room, what comes as a constant message from our residents is things like minor injuries. With our older residents, it's about having to travel to Eastbourne, to Hastings. We've heard it all this evening. Can we not, at the very least, try to get some funding for some pilot schemes, so we can test some of these out? In terms of trying to offer something, put something on the table, if it would help, Homefield Place, which is in my ward, has been declared surplus to County Council's requirements. But I do know that the County Council will be very willing to work in partnership with you to try to perhaps use that site as somewhere in Seaford that is already associated with healthcare, that's well known and well located. So I've offered that to you in case. I really hope this evening has been a really useful opportunity. I would really like to see some positive suggestions for action coming out of this, so that we don't all go away feeling, well, that was all very well, but what have we actually got out of it? So it'd be really good if, for example, we could have some agreement for you that you will go and pursue some locality funding to pilot some schemes, you'll look at home build place, just so we all go away with something concrete. And then finally, what I hope isn't too much of a kind of techie question, this has been a really useful opportunity, and I want to thank the Town Council for arranging it. It's really helpful. But I'm not clear, as a councillor, about what your governance arrangements are, both in Eshed and the CCG, for this kind of public participation, if the public do want to come along and carry on this conversation. So I wonder if you could perhaps outline for us, how your boards work. Are there local people that we could contact to raise these concerns with? Can we come along to your public meetings and raise some questions and keep the dialogue going?
Yeah, so hi, I'm Chanmay. I'm the engagement officer for the clinical commissioning group. We do have a public event coming up. It's on the 12th of October. This one, what we try and do is we try and change the location. So every 6 months we have a public event. And every 6 months we try and change between Eastbourne, Hailsham and Seaford. Unfortunately with Seaford, there aren't many venues that can accommodate 150 people and have the accessibility requirements that the NHS is mandated to have. So one thing I've struggled with this time round is to find a suitable venue. And although we'd had the last one in Eastbourne, I had to switch to either Hailsham or Seaford. And the dates that we have certain days when we have to deliver some public events, and it will be held at Hailsham Civic Hall, because in the time that we needed venues to hold 150 people, we couldn't find one suitable in Seaford. I am new to this area. I'm from Nottinghamshire, so please correct me if I'm wrong, and you know venues that can hold this. It's another part that we have to make sure it's accessible. So we're talking, wheelchair accessible, having the technology for, let's say, if someone needs sign language, if brailing. So if 150 people do come, which is a normal amount for our public events, we have to make it equitable for the attendees. And unfortunately, for the event on the 12th of October, I could not find a venue suitable in Seaford. So
We're just saying Baptist Church, the same as
we
have loads of meetings.
250 people getting there.
are they accessible in terms of disability requirements?
We have loads of meetings there, council meetings.
We've done this before as an excuse, and we've spoken to your predecessor saying, if you've got a problem, let us or the town council know, and we'll find a place for you. And we've said this before.
So what Chan said was that she is new to the engagement team. What she answered is that we have got a process and she's setting up a new one. So just as she was saying that, that's something I've been to the Baptist Church and I think that fits it, but we haven't had that discussion because
and just a quick question, follow up to that. We used to have the CCG meetings, the CCG board meetings in Seaford. We haven't had anyone for a long time. Again, we're going to start the CCG because that way the people can come in and talk to the board themselves. I think that's very, very important that we have that in Seaford.
That's fine. With this time round, it really was a convenience and it was Hailsham was chosen. That's not to say the next meeting cannot be held at, is it Baptist Church in Seaford?
Yeah.
So, I can commit to looking into that myself.
Perhaps you should have meetings more frequently.
Sorry?
Perhaps you should have meetings more frequently.
Yes, we can look into that as well. At the moment, about 1.5 years ago, surveys were sent to all 3 of our regions, so Eastbourne, Hailsham and Seaford, and our public had said we'd like one meeting around springtime and another around autumn time, and that's what we follow it up with at the moment. If there's a change that's required, we can look into it, but it also depends on the resources we have available for us, as each clinical commissioning group is given a certain amount of resource for public engagement. So I'm happy to look into that.
More questions?
So, can I, just for Councillor Lambert, if you don't mind, the pilot schemes funding, I think the answer is, yeah, if be happy to receive, to hear sort of suggestions of what might be funding pilot schemes that are. I think we should also make it clear, the information available of what already has started, like the frailty clinics and where they're held and things to come, and make sure those happen. But if we could identify some specific ones, I've already undertaken to try to look at some of the numbers of patients that go to revisit that work I did some years back, both on postcode and on GP practice number, look at or get someone to be able to drag out from the information systems those, and it's not that difficult, it's just getting their time, and by what specialty and what numbers, and from that might come, do you know, it looks like we could do a such and such a clinic here and that type of thing. But I think it might be driven by, and I do attend as much as I can the local health meetings, the Seaford group, that's Sam, and I would undertake to report it back to there, I think, if that was acceptable.
Yeah. And just a quick follow-up, we do meet with the CCG every 3 months, and during that meeting we identify services that we can provide in CFO, and we try and look at it, and I think we've achieved quite a lot in the last 12 months. We now have some form of X-ray being done, the GPs are providing us, and the challenge we do have is about trying to get this message out to the public, because many members of the public are not aware of that there are many services that we cannot provide locally, both in the GP surgeries and in other centres, and that is how do we let people know about that?
Ms. Brett?
Thank you, Madam Mayor. I'm actually here to speak on behalf of my partner, Patrick Roth, who's unable to be here because he spent the whole day going to Hastings today for some treatments and got back just before I came out. This is from 2 years of treatments continuing. The cancer treatment he had at the EDGH was absolutely brilliant. Staff were the best. Lovely, clean, smiley people, with a Mary Celeste at the weekends, as we discovered when he kept in there for 8 days. Today, going to Hastings for treatment was a complete nightmare. From Seaford, it's over an hour and a half, virtually impossible by public transport, rail strikes, terrible roads and traffic delays. I received a distressing phone call from him when he did arrive this morning to find there was a queue to get into the car park. Luckily, he did manage to get into the car park before his appointment, but he was very, very stressed. Obviously, we are not eligible to use the frail elderly transport service, and if you did, I just don't think it would necessarily get you there in time or back again, when what you're having done is going to take 4 hours. Anyway, our main query and our main concern is really with the provider, because many of his treatments have been delayed by lack of proper project management. Nobody except the patient seems to take ownership of the care pathway. The sick should not have to be chasing the administrative staff for appointments or waiting for 2 weeks for letters to come, nor be sent out after an operation with a file marked "No care necessary" when they're wearing the nephrostomy bag and need weekly dressing. He went 3 weeks with nothing being done. We suggest that techniques adopted from industry in project management are added. A timeline of treatments, chasing points, named responsible people looking to ensure treatments as swift and ordered as possible. The current chaotic management of care lengthens the suffering and probably endangers as well as degrading the life of patients. Individual staff dealing with treatments are by and large excellent, but the management and the project pathway management is actually missing. I dispute the fact that you have a choice to your operation because it's already been told when he was in Eastbourne the last time that when he has his kidney removed, it would be at Hailsham. And we now understand that the consultants in Eastbourne can't look at the information about what's going on in there because it's a different health authority or different care provider trust. So you can understand that I am very, very concerned about this. And seriously, thank you.
I'm going to say something first, because if I like it, I can remember. I mean, the way you've outlined that sounds horrendous to me.
It is horrendous.
Yeah. I wouldn't try to defend it, but I couldn't answer it either because I don't know, and I wouldn't be able to because your comments would have to be aimed at the people providing
Providers, yes, they are
the care, and you did acknowledge that at the very beginning. But I think you should raise it, because it does sound wrong. It doesn't sound organised. I do know, because when I said to you when I was standing down there, that I deal with the Trust on their achievement of the cancer standards in this case. So I do know that they employ people who are called patient trackers, who are supposed to follow patients through the system. I do know that they have a computer system which they call it's a real-time PTO patient tracker system that they've got. So it sounds to me from what you've said that there is a failure in systems that do exist that I think should be investigated. Unfortunately, it does mean either you or your partner, I think you said, going through with someone in Esh what actually happened.
Yeah, and that's what I'm saying.
The cancer treatment was actually stopped because he's officially got the all clear. He's supposed to have maintenance, but because he's now got a problem with his kidney, which has been caused by some intervention that was done in East Surrey from some years ago, and has to have another operation, it's on hold. So he's not actually getting any cancer ongoing care at the moment at all.
Well, I'm just going to reiterate, it sounds to me that both you and he are unhappy, and you should take that forward, not, with respect to Stuart, you should take it
So
forward.
we should actually make a formal complaint, is that what you're saying?
Or do you still have to...
We've
Is
got
he ready to
powers.
do that now?
We've got powers for our patient advisors and liaisons, and
He went there, they didn't seem to want to understand what was going on.
Well, if you feel like that, you should make a formal complaint. I'd say, I'm sorry.
We didn't get anywhere with PAL last week.
No, if that's happened, then I think at least if you put in a formal complaint, then there will be a formal response. I'm afraid it's not. It isn't my. I'd love to sit here and give you a better.
No, you don't. I know you don't know. I mean, you don't know. But the crux of this is, if there was a proper care pathway and proper management, project management of patients, this wouldn't happen. I mean, so he's been to the EDGH, he called the ambulance out one night and they offered him to go to Hastings or Brighton, not Eastbourne. It's just the whole thing, it's just a complete chaos.
With the greatest respect, we really couldn't. I would encourage you to follow through because you are genuinely seriously concerned. I would encourage you to do that, but there's nothing either we could say because we don't know the case, and it would sound a bit trite if we
Of course,
tried
it's
to
quite worried now that he's
guess
not going
what's
to get
happening.
good treatment if he complains.
Lots of people.
So I can have your assurance that nothing on his ward will happen just because he's complaining.
Absolutely.
I guarantee you that nothing. I mean, I can understand how some people do feel worried if they raise a complaint that the clinician. But no, I think we take on board the complaints and it's about improving care and learning when things go wrong, and we've got evidence of that. So no, it wouldn't. But if you wanted to have an informal discussion, then just I'll take some details from you. Okay.
Lady in the third row, blue blouse, yes, you.
I've got Denise Savage, local resident. I've got a question about 18-week period from referral to completion. My husband has had a 52-week wait for an ear operation. He actually went through referral diagnosis, he had a pre-op, it was all going to happen, and that was 52 weeks ago. Now, we've also contacted PALS, and in the past, I must admit, I would speak very, very highly of them. They have certainly helped me when I was referred to Brighton. But the PALS at Eastbourne haven't really been very proactive, and we are left waiting. He'll have to have another pre-op. Does it mean that it's going to go on endlessly, or do we keep banging at doors? Because that seems to be the way in which as areas in the health service seem to operate. So 18 weeks or 52 weeks?
And you're talking about at the DGH?
Yes.
I'd really want to follow that one up as well, because I see all of the figures, I see all of the weight, and if you'd have turned it on its head and said to me, what's the longest weight you've got formally in the way it's counted, I would have said 40 weeks.
Even 40 weeks is unacceptable, isn't
Well,
it?
I'll explain the way the standard works. From referral, the clock starts counting. And there used to be, up until last year, 3 different counts. There was for people who, the admitted pathway, so if once it was decided the patient should be admitted for treatment, the target was 92% of those who would be admitted should be seen within 18 weeks. But there was a back, because 92%, that means 8% of patients can wait longer than that. And I think in some places there was a time when once those people had breached, they stayed breached. So there was also a count for the non-admitted pathway, which meant that people were going to be seen and dealt with mostly in an outpatient environment. So you might see a dermatologist, he'd eventually look at you and say, take this cream and it'll be okay, and that would be the finish of that treatment. And then there was a third count, which was 95% of patients who, which was the total number, so it included both of the previous numbers. So it was all of the people who were still in the system, hadn't been completed, and that's the one that now the government monitor us to, that. Within that, there is a backstop, which trusts report and go right up to the Department of Health. They count the number of 52-week waits, and I would have said to you now, there are none in this area. There are a lot in other areas, there are none, which is why I'm really intrigued in this case. And I would have said to you, as I said, that the maximum weight was 40 weeks. I think it's 36 weeks, but I would have hedged my bets and said 40. So I'm very surprised. Now, there are some technicalities in it that the clock stops at different times when certain treatments are started or if someone's not available. But 52 weeks, I'm surprised and disappointed at, and I'd like to know, to take your exact details so I could investigate that specific case.
Gentleman at the back.
A couple of things. The commissioning gentleman said it was down to private companies to come forward with ideas and proposals to them in the area. Is that it? Is it as random as that? How we get our services?
No. Can I answer that one? Because I either misspoke or you misheard. But my answer about private companies coming in was about to a question, why don't you set up lots of providers locally so that all of the healthcare for the people of Seaford or is received? And I said, the CCGs aren't allowed to provide care, and we are required to buy care. But we can't, we buy care of people who say they want to come into the area to provide care. Now, I mean, at the moment, there are, I mentioned, for example, it's called AQP, any qualified provider, and the government set it up that there's a process where people can apply and say, I want to provide, I mentioned it earlier, hearing services locally. I want to provide outpatient services for certain specialties locally. Someone could come in and say, I want to provide X-ray services locally. So if those people, the lottery is that if people say commercially they want to make a go of a business here in Seaford and set up and qualify in accordance with the process that they are able to provide that quality of care and quality of service. So
I think that's what I understood.
yeah, so then people have got to want to come and set up a business to provide that care is what I'm trying to get over.
And the second point, for transport, I guess you do some sort of economic analysis, but is the patient's time and difficulty, what weight is given to that?
I'm not sure. There was, you took about in them waiting for patient transport, waiting to be picked up.
Your services provided in Bexhill or Hastings or whatever, that's an economic thing to do for the specialists. How much weight is given to guys who have the time taken for guys to have to travel from Seaford to Hastings? Does that come into the equation?
Yeah,
And if so, how?
I can answer you to the extent that I was aware of the trust came up with a case that they wanted to provide, it's for the macular degeneration service, they wanted to provide it from one place centrally in Bexhill, and they knew they could provide it from there. So they had to do an analysis about where their patients travelled from in order to get to that service and how they travelled there, which was why I was able to say that in agreeing to let them set that up, and there was a very strong clinical argument, we also said that you have to make sure that the patients at the far ends have you enable them to get transport to do that. That's probably the truth as far as it went. I'm not aware of any more in-depth
There's no further
analysis.
saying a patient is losing so much money going all this, spending time doing this. That didn't come into the reckoning or the equation.
No, I think in all honesty, no. It was more on the numbers and how do you make sure that if you're going to provide that better service there,
yeah, but
5 miles further away from where it currently is.
The question is it a better service?
I understand the question, and I said that wasn't done. No.
Just a third little thing, there's such things as lost papers and lost documents, which I spent a year waiting for a follow-up because of that. So that wouldn't show in your records. Thanks.
Sorry, can you give your name, please?
Frank Cross, my name.
Sorry, just on what Frank's raised. A lot of the projects that we're now doing, Frank, they do have patient representatives or lay members attached to them. So one of the initiatives the CCG is rolling out this year is that for every new procurement we have, or every new plan, let's say at the moment we're working on musculoskeletal services, we do ensure that there are 2 patient representatives attached to each project. So this has been a way for the CCG, and it is a new initiative in some ways. It's a way to say, so for every project manager, engagement officer, clinical lead there is on the project, there were also 2 people providing the patient's viewpoint to ensure that we do sort of remember why we're doing it. And this is something we will be rolling out for several projects as they're being either planned or we procured within the area. And I do apologise that you haven't had this experience. At the moment I'm working on the musculoskeletal services. We've done one for Eastbourne, Hailsham and Seaford side and for Hastings and Rother. And for both of these services we have recruited patient representatives to let us know about what they are experiencing locally and how whoever wins, let's say, the contract for that service, they have to reach a certain patient standard. This is being done by adding 2 patient representatives on our steering committees.
Well, that's promising, but what I was wondering about was a sort of economic model which ignores patient time, patient inconvenience, dare I say.
Yes.
And maybe that could be addressed.
It is being addressed. Economics within our steering group does include patient economics. We do want not just a monetary rate of return, but a social one. So we do need to ensure that the patient's well-being is taken into account. And things like waiting time and location are some of the factors that our providers are, we do judge them to the extent, but also sometimes we simply don't have enough providers bidding on certain projects because to certain providers they want to make some sort of benefit for themselves. So if we only have 2 providers bidding, no matter how attractive we've made the project, it can become a challenge, but we have ensured that for every project we now do, there are 2 patient representatives.
Chair, can I just ask you the conflict break? So yeah, that's
Are there any more questions from the public?
One just a quick question about, you talked a
Could
lot
we
about...
have your name, please?
Sorry?
Have your name, please?
Dee Kellaway. There's a lot of talk about public consultation, but this is my first meeting, and it's only because of Carolyn Lambert that I heard of this meeting. Where do you advertise? I spoke to several mums at school, none of them had heard anything about this. So where do you advertise?
This meeting isn't organised by the NHS, it's organised by the Town Council, so it's our meeting, not the
Yes,
NHS
no, I
one.
appreciate that, but they're saying there are public consultations about various things, but I've never heard about it.
We have a newsletter that's sent to, I see, around 3,000 people. I think I have a database essentially where people in the past, when I'm studying in a shopping centre or a supermarket or a hospital, I'll have a sign-up sheet that just asks for people to enter their details. And I've done it at Seaford and at other places, and whoever signs up goes onto this database and I send them the information. Oftentimes we do it in local shops, so Sainsbury's notice boards, your Tesco's, Morrison's, we've done it. So, and sometimes if it is, we are allowed to, we do it with local authorities, but if you feel like there's a place in Seaford I'm missing, we'd be happy to take that on board.
What about like advertising in the library or this GP surgery where a lot of us visit these places?
I have advertised at the library before.
I think there's something we should take back. I mean, I think Esh originally approached the Town Council, whilst as Town Council then took them up.
We have had a meeting this evening. We did meet the libraries and the GPs and the paper and Facebook and Twitter. And we got 10 people.
Yeah. And at other times, and I've been there, there have been 250 people from Seaford.
It's winter, it's cold, windy.
So it's still something we need to take account of, isn't it? And I think I'd also take a comment back from this meeting that certainly the people of Seaford would like to have a lot more engagement, so we should work out how we can do that.
I was a bit intrigued that you mentioned the Seaford Medical Centre, but not the other large practice in the town. And also as a sort of supplementary to that, the Seaford Medical Centre has got patient participation group, which I go to, and it's very active. But I understand that the other surgery doesn't have one. Should it not be the case that all primary care has a patient participation? Could you answer the first thing first?
Well, the first one, I mentioned the medical centre because I was talking about part of the engagement I've done in the past, and it was around the development of the Seaford Medical Centre. Sometimes the GPs from the old school practice used to go to that because they were involved in it, and currently both practices meet up monthly, and both Chad and I started to go to their meetings, so it's not like they're excluded, it's just that what I was referring to was a specific thing around the redevelopment of the medical centre.
But participation group, I think.
Participation group. I'll be honest, I don't know what, I know that there is an expectation that every practice does have a patient participation group, and I'm also aware, because I've heard of it, that not every practice does, but I don't know what compulsion there is for the CCG to enforce it, and I don't believe there is. I think it's by encouragement and offers of support rather than right, we're going to come down here with our big carrot, sort of thing. So practices are independent practitioners, but one of the requirements of them operating that they do have a
do a refresher on setting up participation groups, not just for where there are gaps, but also for the fact that a lot of groups haven't had as much engagement as they would like. I think the next event is tomorrow with Health Watch, and there'll be a few rolled out across the coming months. But over winter, usually Health Watch has said there isn't a lot of interest, so they start in the spring next year.
Councillor Nation?
Just two further questions for me. We do have this group meeting. We have a meeting which we meet every autumn with the local NHS. The GPs attend, the CCG attends, Sussex Partnership NHS Trust attends. The other people who refuses to attend is just Ash. When Darren Grayson was the chief exec, Ash said, "No, we won't talk to you. We won't come talk to you." You had the new chief exec, and we spoke to Gary East, one of the assistant directors. Gary, I agreed to attend the meeting. Then he said, so I couldn't make it, I can't attend. And then he said to the client, saying, sorry, we are a provider of NHS, we don't have a duty to meet with you. We only have a duty to meet with the CCG. So I think it's quite important for people to see, because with this meeting that we do have, is our chance to feed local people's concerns to the NHS, or to the NHS. Everyone attends with Ash. Please give some form of commitment to get someone to attend this meeting, grant attendance as well. And if you can attend the meetings every 3 months, it'd be very, very useful for us. So can I have my commitment that you will try and attend, send someone from Ash to attend the meeting? Second final point. This has been very, very useful, and I wonder if we can have this more frequently as well. And but next time to bring in the GPs as well. Because the primary care is also quite important, and I think sometimes if you have the GPs in primary care, some of the questions I've asked Graham today is set over as the GPs. So if we can have this meeting, something like this again, maybe once every year, with the GP as well. So we have primary care, the provider, and the commissioner together in one room, organized by the town council, and I'm sure the town council will gladly organize it. That would be useful, so to get another commitment that you would support it if we have this meeting again in the future.
Well, I would say yes. I might question whether it should be us who will do it as an engagement process rather than asking the town council to do it. I think we should consider that as part of our engagement process, and we would set one up. I think we should say it. On your first point, I'll explain to Ruth and Lynette what the other group is and why I think it would be a good idea for someone. And just so you know, Gary is now works for me, he moved over to it, so he knows his mind about it. But yeah, I'll explain to Ash, and I'm pretty sure that his chief executive support someone coming to that.
Any more questions? Right, well thank you very much for coming here, and many, many thanks to Lynette and Ruth and Graham and for all your very good input.